Good morning, everyone. Thank you for joining us today to discuss Medicare coverage of colorectal cancer screening. My name is Karen Curtis, and I am a provider outreach and education specialist here at WPS. Today, I am joined by my good friend, Aline Sigler, who also is my coworker. Aline is going to be helping me out by monitoring the chat. She's going to help me out with questions, as well as providing all of you with some links and information. Now, earlier this month, our coworker Jennifer Boniface held a webinar on colorectal cancer screenings that covered more of the clinical aspect. Then we had another coworker, Mary Muko, who had a webinar on common colorectal surgery denial and rejects. These are both on the WPS Encore presentation webpage as well as our YouTube channel. Today, I'm going to cover more of the billing aspects of it. So just in case you want some more of that other information, those webinars are available. Now, I have just a couple of things to cover before we get started. First, if you haven't downloaded a copy of today's presentation and you would like to, there is still time. A copy can be found on our live events page, which is located within the WPS Training Center. Here you can also find a list of our upcoming events. Aline has added a link into the chat if you need to get there quickly to download the slide presentation. Our training center also contains a web page for our encore presentations. Videos are available for up to 90 days, and they can be watched on our webpage without you having to go to YouTube. We know that some of you may not be able to access YouTube from your company computer, and we want you to be able to receive the education that you're interested in. Each encore is posted with a link that will allow you to download a copy of that presentation. And it also gives you a chance to complete a survey to provide feedback on that event. Today's presentation is being recorded, and if there are no technical issues, this will be posted to our website soon. Now later, there will be a question and answer session if time permits. If you have questions related to today's topic, please send those using the chat feature. I did receive some pre-submitted questions, which I will answer at that time. Now, if there's any questions that I don't get to, or if some require additional research, then an email providing those answers will be sent to everybody in attendance today. Our goal is to provide you with an excellent customer experience. We want to know how we're doing, so later in the presentation, you will be given the opportunity to provide feedback on today's event. This is your chance to let us know what we're doing right, let us know if you feel there are areas where we improve, and it also allows you to give us input on what types of education you'd like to see in the future. So while this is a CMS survey, WPS does look at our results, and we do our best to make the improvements that you ask for. Now, here at WPS, we do our best to provide you with accurate, up-to-date education. Now, if you have worked in Medicare for a while, you know that Medicare rules and regulations can change. So for this reason, the CMS website should be checked for updates, and the federal regulations are going to take priority over anything presented today. Later during our question and answer session, I am going to answer questions based on the facts given. So I just want to remind you that any changes to that information could change the response given. We also are not able to guarantee payment for services. Medicare rules will always determine final coverage. And if you have a claim-specific question, we do ask that you contact customer service. They can access your claim and provide you with an answer based on how your claim processed. Lastly, I need to let you know that CMS does prohibit the recording of this webinar. We are recording the event so it can be posted to our Encore presentation webpage and YouTube channel. So there really wouldn't be any reason for you to record it or take screenshots. If there's something missed, the information will be available to you within about a week. And today I will talk a little about colorectal cancer before we move into Medicare coverage and how claims should be submitted. This is the American Medical Association's copyright notice for CPT codes. During this presentation, I will provide billing information which contains CPT codes. So this notice lets you know that Medicare does not own the codes or their descriptions. We have another copyright notice from the American Hospital Association National Uniform Billing Committee. Now, this notice is required because I discuss coding that would be included on a UB04 or an 837I. The American Hospital Association is not responsible for, nor were they involved in the preparation of this material or the information that is provided today. So let's start with a little information about colorectal cancer. Cancer occurs when cells begin to grow uncontrollably instead of following the normal cycle of growth, division, and death. Colorectal cancer is cancer that begins in the colon or the rectum. For most colorectal cancers, this abnormal growth of cells occurs within the inner lining and forms a polyp. As we get older, it's more common for polyps to develop. Most are benign, but there are some types of polyps that can change into cancer over time. And if these polyps go undetected or are not removed, then the cancer can spread to other parts of the body. Colorectal cancer is the third most common cancer worldwide and is the second leading cause of cancer-related deaths. Most cases occur in people over the age of 50. As far as lifetime risks, about 1 in 24 men and 1 in 26 women will develop colorectal cancer. Of course, each person's risk can be higher or lower depending on their risk factors. The good news is that the number of people who are diagnosed with colon and rectal cancer each year is decreasing. Now, they believe that this is in part due to people getting screenings, but there are other reasons. Increased screenings has allowed doctors to find polyps and remove them before they develop into cancer. Screenings have also allowed for colorectal cancer to be found earlier when treatment can be easier. In addition, treatments for colorectal cancer have improved over the years. But individuals also play a role in identifying risk factors and taking control over their own health. So what are the risk factors? First, let's talk about controllable risk factors. Risk factors that patients can work on to reduce their own risk of colon cancer. First is being overweight. Being overweight or obese can trigger chronic inflammation, higher insulin levels, and changes in hormones. These changes can promote cell growth, which can possibly lead to the development of cancer. After all, cancer is the result of uncontrollable growth and spread of abnormal cells. Type 2 diabetes causes the body to have high insulin levels, high blood sugar, and increased inflammation. These factors create a favorable environment for the growth of cancer cells. What you eat can contribute to your risk of developing colorectal cancer. A diet high in red and processed meats has been linked to higher risks. Processed meats have been found to contain chemicals which can be carcinogenic. Diets high in saturated fat can contribute to inflammation, which can potentially increase a person's risk. On the other hand, diets with high fiber fruits, vegetables, and whole grains have been associated with having a lower risk of colorectal cancer. I feel like the effects of smoking are pretty well known for multiple types of cancers. If we look specifically at colorectal cancer, the carcinogens found in tobacco smoke damages the DNA. This damage can lead to abnormal cell growth, which can increase polyp development. With increased polyps, the chances that those polyps can become cancerous also increases. Alcohol increases colorectal cancer risks in a few ways. It can damage DNA, make changes to gut microbe, and can cause inflammation and alter hormone levels. All of these can promote uncontrolled cell growth. Lastly, a sedentary lifestyle has what I would call a layered effect on a patient's risk for colorectal cancer. First, a sedentary lifestyle can lead to obesity, which is already listed as a risk factor, but there are other changes that can happen within the body. There are metabolic changes that can occur. Being physically active helps regulate insulin levels and maintain a healthy weight. Being sedentary can lead to insulin resistance, which can contribute to high blood sugar levels, which can increase cancer risks. It can also alter a person's gut, which can cause inflammation, and that is another risk factor. So now let's look at some of the risk factors that are out of a person's control. While it isn't unheard of for younger adults to get colorectal cancer, the majority of cases occur in individuals over the age of 50. Race can have an impact. American Indians and Alaska Natives have the highest rate of colorectal cancer in the United States. Sex at birth can have an effect. Studies have consistently shown that men have a higher incidence of colorectal cancer compared to women. People who have had their gallbladder removed have a slightly higher risk, although researchers have not quite been able to determine why. Patients with a personal history of polyps, irritable bowel disease, and radiation are at increased risk, specifically radiation that has been received to the abdomen or the pelvis area. A family history, as well as inherited mutations, can increase a person's chance of developing colorectal cancer. 1 in 3 people who develop colorectal cancer have family members who also have had it. About 5% of those who test positive have inherited gene mutations. So now that you have a little general information, let's move on and talk about Medicare coverage. Here's a list of the tests which can be billed to Medicare in order to screen for colorectal cancer. The computed tomography colonography is new as of January 1st of 2025. You may also notice that barium enemas are no longer listed. CMS removed code G0106 and G0120 from coverage effective January 1st of this year. For tests such as Cologuard and blood-based biomarker tests, patients should be entitled to Medicare Part B. They should be between the ages of 45 and 85. They should be asymptomatic and be at average risk for developing colorectal cancer. Now for colonoscopies, FOBT, flexible sigmoidoscopy, and CT colonography, patients should have Medicare Part B. They should be aged 45 or older with normal risk for developing colorectal cancer or be at high risk for developing colorectal cancer. So you may be asking, what is considered a high-risk individual? So here I have provided the characteristics listed by CMS. So this looks a lot like the list of uncontrollable risk factors that was published by the American Cancer Society. For the first bullet, when CMS says a close relative, they're referring to a sibling, a parent, or a child. They include family and personal history of polyps, personal history of colorectal cancer, and inflammatory bowel disease, including Crohn's disease and ulcerative, I'm sorry, I'm not going to be able to say it today, ulcerative colitis. Now for these next two slides, I took information straight off of the Medicare Preventive Services tool because each test has a different frequency. So I have included a link in the resource section, and we are going to take a look at it a little later. Most of these are pretty straightforward. I sometimes get asked questions about what does CMS mean when they give a frequency of 12 months? Does that mean that the service can be performed at least 365 days since it was last billed? And the answer is no. When CMS says 12 months, that means that a full 11 months must have passed since the month after the service was last performed. So for example, if a patient received a screening FOBT in January of 2024, you would count 11 full months starting in February. So that means the patient would be eligible for another screening FOBT in January of 2025. Now, when you look at the screening flexible sigmoidography, there are a few things that you have to take into account when figuring if the patient is going to be eligible to receive another screening. So the service is covered once every 48 months. So again, this means that at least 47 months have passed following the month in which the last covered flexible sigmoidography was performed. The exception is if the patient does not meet the criteria for high risk and has had a screening colonoscopy within the preceding 10 years. So in that case, the patient will have to wait until at least 119 months have passed before the month that they received a screening colonoscopy. So as you can see, this is why I just kind of copied and pasted it from that resource because it is so different for each one. Now I did the same thing for the high-risk patient frequency. This again is directly from the Medicare Preventive Services tool. This seems to be a little bit more straightforward. It does say for the screening colonoscopy that it should be covered every 24 months unless the patient received a screening flexible sigmoidoscopy. Then Medicare may cover a screening colonoscopy only after at least 47 months. I'd like to stress the words used are may cover. So I definitely wouldn't take that as a guaranteed payment. So let's take a look now at how we're going to get those claims submitted to Medicare. First, I would like to make you aware of some changes that have been put in place within the last 6 months. I mentioned this earlier, but effective January 1st of this year, CMS added CT colonography code 74263 as a covered service, while they removed barium enema HCPCS G0106 and G0120 from coverage. Effective October 1st of 2024, 5 new ICD-10 codes were added to the list of covered diagnosis codes. Diagnosis code Z86.010 was removed from the list of covered codes effective September 30th of 2024. Here is a list of the CPT and HCPCS codes that can be billed to Medicare. The code that you see in red is the newly added CT colonography code 74263. Now here, I've taken the billing and the coding information that was in the internet-only manual, and I put it into a chart. I was hoping this would be a little easier for you to read. The manual has not been updated yet to include code 74263. I tried doing some research, but I wasn't able to find anything, like I wasn't able to find a specific type of bill or a revenue code. So hopefully CMS will get the manual updated soon with that information. I did add some notes here that for critical access hospitals method 2, they would use revenue code in the 096, 097, or 098 for professional services, and revenue code 75X or other appropriate codes for the technical or facility component. You'll also see, which you don't see a lot, is that some of these tests and services can be billed on a type of bill 14X. Those are for non-patient laboratory services. As of January 1st of 2023, frequency limitations for a screening colonoscopy do not apply when it is done as a follow-up to a non-invasive stool-based test that received a positive test result. Claims for the screening colonoscopy should be billed with modifier KX, and this will help bypass those frequency edits. A modifier PT would be used if during a screening flexible sigmoidoscopy or a screening colonoscopy, a lesion or a growth is found which results in a biopsy or a removal of the growth. You would then bill the appropriate diagnostic procedure with anesthesia and anesthesia with modifier PT. Now, there are some special billing instructions for inpatient hospital claims. Maybe the patient has recently been admitted, or maybe they've been there for a while and they've exhausted their Part A benefits. So in these situations, services should be billed on a 12X type of bill using the patient's discharge date as the date of service. And this should allow you to avoid any common working file edits that would cause the claim to reject. So I'd like to let you know how to check for eligibility. That way you can avoid some frequency edits. You have a few options when it comes to checking patient eligibility. We have the WPS Secure Net Access Portal, which is often referred to as the portal. Users must be registered with WPS to view a beneficiary's eligibility information. When you visit the WPS website, there is a box that takes up the majority of the screen. This is where you can register or log in if you have an account. Direct data entry, or DDE, is an option for providers who bill using the Fiscal Intermediary Standard System, or FIS. This also requires you to register with WPS. Users will have access to Common Working File, which provides eligibility information for Medicare beneficiaries. The HIPAA Eligibility Transaction System, or HETS, is available for both Part A and Part B providers. It provides access to eligibility data in a real-time environment. Now this does require files to be submitted through electronic data interchange, so a trading partner agreement is required. Response files are accurate at the time of transaction and should not be interpreted as a guarantee of payment. Now here I've included a screenshot of the colorectal cancer screening portion of the portal Preventive Services tab. This was taken from our test for environment, so it is fake information, but I at least wanted you to see what it looked like. You can see that it lists all the procedure codes. It gives you a next eligibility date. So this could be something that if you got access to the portal, it would help you to avoid those frequency edits. Now, I provided some resources that I hope you will find helpful. I'm not going to go through all of these, but there are a couple that I really do want to show you because it provides some information. I found it was easier to read than accessing the online manuals. So the first one I want to look at is the Medicare Preventive Services tool. And we're going to go here to the colorectal cancer screening. You can see right here, it does give you what information has changed. It also provides you with a link to the NCD. Here's where I wanted to call your attention to. It talks about the ICD-10 codes. So if we click here on this link, let me scroll up to the top here. It gives you that list one is a partial list of diagnosis codes indicating high risk, and it is only applicable to G0105 and G0120. So it provides you a list of diagnosis codes that would be applicable for those tests. If we scroll down here, we have two diagnosis codes, and these are applicable to the 81528, which is the Cologuard, and the G0327, which is the blood-based biomarker test. And it does tell you only one of these diagnosis codes is required. There's a couple other things that I wanted to point out. This does give coverage criteria. Down here, it does talk about the KX modifier, putting that on the claim for the screening colonoscopy. It gives you the frequency that we went over, patient payment. There was a pre-submitted question. I will discuss that in just a minute. It also, down here, it gives you other notes. So it talks about paying for anesthesia services. But this is just a tool that I wanted to take you guys out to show you, because I do find that it takes all the information from the online manual and it just kind of puts it in an easier to read format. And again, provides you with links to the NCD so that you could go out there and look up the requirements too. Another resource I wanted to show you was the Modifier PT Fact Sheet. This is a WPS resource. It tells you that it's used for colorectal cancer screening tests that are converted to a diagnostic test or other procedure. It tells you correct usage, describes incorrect usage, gives you some notes, and also provides resources. So that's another one that I wanted to make sure that I showed you guys. I did also include some of the eligibility resources. So this just has to do with the portal, DDE, and the heads that we talked about. There's also a CMS fact sheet for help with any sort of eligibility checking. So before I ask Aline if there are any questions that have come through in the chat, I would like to answer the pre-submitted questions that I received. I received a few questions about canceled or discontinued colonoscopies, so I'd like to discuss that. When a colonoscopy cannot be completed because of extenuating circumstances, Medicare will pay as long as the coverage conditions were met to begin with. When submitting the facility fees, you're going to want to include modifier 73 or 74. Modifier 73 would be used if the procedure was canceled prior to anesthesia being submitted or being administered, while modifier 74 is used when anesthesia was administered, or if the procedure had already started and then had to be discontinued. The claim for the professional services would be billed using modifier 53. I will take you back out to our website because we do have some information out there. I'm going to go to our home page, and then under the quick links, we have modifiers. I am under Part B right now, but if we scroll down, there's a modifier 74 fact sheet that can give you some information on using that correctly. Sorry, just give me one moment. There's a modifier 73 under the discontinued procedure modifiers. There's also modifier 53. So those three modifiers that I told you would be used when the colonoscopy is canceled or discontinued, we do have fact sheets on all three of those modifiers to help you with billing them correctly. I also received some questions regarding diagnosis codes. So I showed you the link that can be found in the Medicare Preventive Services tool, but you can also find information in the CMS Internet-only manuals. The Medicare Claims Processing Manual I had right here, Chapter 18, that is the section on preventive services. If we go out here, and it's in section 60.2. It does go through each of the tests. It'll give you information about who should perform the services. I'm sorry, I'm trying to find somewhere it gives you a specific diagnosis code. And I'm sorry about the scrolling, guys. It talks about the frequency. Like I said, the Medicare Preventive Services tool just kind of makes things more simple. Here it has, for the Cologuard, it tells you down here Z12.11 or Z1212. So the internet-only manual is another place that you can go if you are looking for specific diagnosis codes that need to be built with the services. Another question I received was, will there be a denial when a provider and the facility both bill G0121? Now, while I can't make any promises, this shouldn't occur because the facility is billing for the facility fees, and I'm making air quotes right now. So what I mean by this is that the facility is billing for use of the equipment, the room, etc., while the provider is billing for professional fees. So like doctor's fees, things like that. So although both claims are for a colonoscopy, they are billing for different services as part of the colonoscopy. So I hope that makes sense. One claim is going to be going through the FIS system. The other claim is going to be going through the MCS system. Another question, does a patient with a form of IBD, Crohn's, or colitis qualify for screening or is it considered diagnostic? Now, CMS does put individuals with Crohn's or colitis in their high risk category. These patients can still receive services such as a screening colonoscopy. It's just that you would use the high risk guidelines and frequencies for that service. Patient responsibility when screening turns to diagnostic. For that question, I will go back to our Medicare Preventive Services tool. Down here with the patient pays, it does say to indicate a screening colorectal cancer procedure has become diagnostic or therapeutic, you would add modifier PT to at least one code on the claim. We continue to waive the deductible and for dates of service from January 1st of 2023 through December 31st of 2026, they will apply a reduced coinsurance of 15% for all procedure codes identified here. So hopefully that answers the question for that one. Another question I got was when a patient has a personal history, they gave me a couple different kinds of polyps, diagnosis code Z86.0101, and is considered high risk. Is it correct to code the screen Z12.11 along with the personal history of colon polyps? This seems to be a very gray area, and I'm hoping one of your webinars will cover correct coding situations. So is it correct to code G0105 with Z1211 and Z860101? I do want to go back to the list of diagnosis codes. And the code that I was asked about was G0105. So here we have the G0105. Both of the diagnosis codes that you asked me about are listed. Here is the Z1211. And here is the Z860101. So both of those are listed as applicable codes for the G0105. Why has Medicare not updated their system to show Z860101 as a billable diagnosis code with G0105? We are having a lot of claim denials because of this issue. Now, I don't have access to the system, but I did check to see if any of our system logs were showing that there were any known issues with high-risk colonoscopies, and I couldn't find anything. So what I do suggest is that you call customer service. The reason is because they can look up your claim. They can see if there's something else on there that is causing the denial. And also, if they can't find anything wrong with your claim, and it's supposed that diagnosis code is billable for the G0105, customer service can do a referral to the systems department. And that way the systems department can take a look at it and see if there's an issue with it. I know that this was one of the codes that was added January 1st. So normally those system issues are detected right away, but I mean, who knows? Something could have been put in after that caused a glitch. But definitely you'll want to have customer service take a look at that and possibly refer it to systems. The next question I got was understanding when the colonoscopy is actually a screening. Many doctors just say screening, and it is hard to tell sometimes. For example, if a patient has a colonoscopy every 5 years, when do we know if it is screening or not? The only option you really have is to code the claim based on what's shown in the medical records. So you know, if the doctor's saying it's screening and he's putting that in the medical records, then that's how you would need to code it. And the reason you want to do that is because if anything were to get reviewed, you're going to want your claim to match the medical documentation. So hopefully that answers your question. Why does Medicare not cover office visits prior to screening colonoscopies? This would be another question that would need to go to customer service. I'm not sure why your office visits are denying, so it's hard for me to try to provide an answer to that one. When is it appropriate to code a consult prior to a screening colonoscopy? Now, MACs are prohibited from offering coding advice, so unfortunately, this is not something that I can answer. Again, maybe if you have a coder in your office, they could look at the medical documentation and go from there. Screening versus diagnostic with a patient documented symptoms of diarrhea. Screenings are for patients that are asymptomatic, but a healthcare provider is the one who's going to determine if the patient's services are screening or if they're diagnostic. If a patient meets with a doctor days or weeks before the colonoscopy procedure to discuss concerns, preps, etc., is that visit separately billable or is payment included with the procedure itself? I would like to refer you to our website for the global surgery guidelines. I think that maybe that could probably provide you with some guidance that might help you with those visits. The last question, pre-submitted question I got was, what is an appropriate ICD-10 for an evaluation and management visit prior to the colonoscopy? So again, MACs can't provide coding advice, but you're going to report the ICD-10 code that best describes the reason for the evaluation and management visit. That is all the pre-submitted questions I have, so I am going to ask Aline if anything has come through in the chat.
Hi, Karen. Yes, we have gotten a couple questions, and I want to thank everybody who sent those in. I have two questions that are kind of related, and they go along with some of what I think that you just discussed. This says CR, change request 13828. Business Requirement 3 states the new diagnosis codes effective 10/1/24 are not implemented until 4/7/25, and that's what customer service told them when they called. So I don't know, I'm going to drop the link to that change request in there, but can you speak to why a change request would be implemented on one date and then effective another date?
Sure. There's times when CMS will issue a change request and they'll give us the changes, and sometimes they even they'll divide it into system changes versus non-system related changes. And they can have different implementation and different issue dates for all of these. So the issue date just means when we've been made aware of it. But the implementation date isn't until those changes actually go into effect. Aline, can you give me that diagnosis code again?
Let's see. She didn't give me a specific diagnosis code. The change request is 13828. Oh, she just put it in chat. 86086.0100.
I thought that was one of the ones they listed up here. Yeah, so that was one of the ones that they listed here. They said It was effective October 1st of 2024, but they're saying the implementation isn't until April.
Yeah, and I know you can't see the chat when you're sharing your screen, but change request 13828. And I did, while you were talking, I did find it and I dropped a link to that in the chat. And it does say for business requirements that the date for that is 4/7/25. And so that probably coincides with a quarterly release, perhaps.
Yeah, and a lot of times what they'll do is that if any claims, so here it says that's effective October 1st, 2024. So if your claim gets billed and the changes have not been put in the system yet, normally what they do in those situations is they have the contractors do mass adjustments. So they make us go through and find all the denied claims that contain covered diagnosis codes, and we'll have to adjust those claims for processing. So hopefully that maybe explains it a little better.
Yeah, so more to come on that, I'm sure. Let's see, I'm scrolling back up here. If a low-risk patient received a screening colonoscopy, but later became high risk due to changes in their health, would they become eligible for another screening colonoscopy if they were still within the 24 months?
Let me go back and look at. So if they were moved to become a high-risk patient, then the screening colonoscopy would be once every 24 months. Now, I can't promise you that you can submit it and it can get paid, but if we look at the information provided by CMS, a high-risk patient is eligible every 24 months.
Next question. If a doctor finds hemorrhoids or polyps during the screening colonoscopy, but does not treat them, does the colonoscopy remain screening, or does that need to be converted to diagnostic?
I have not found where CMS has given us any instructions as far as this specific scenario meets a diagnostic. Again, to me, that's at the discretion of the healthcare provider that's performing the colonoscopy. But I have not found anything that CMS has given us that is that specific.
Okay. All right, let's see. Sorry, I had a little back and forth here on one of those. When will CMS start paying for the personal history of polyps? We've been getting rejections since October 1st, 2024. I'm wondering if that has to do with the diagnosis code issue and the implementation date that we already talked about. I'm not sure.
Yeah, I'm wondering that too. If it is one of these diagnosis codes, that could be the exact issue. So again, you're getting denials and rejections, and then once the system gets updated in April, then they're going to go back and adjust all of those claims. Or they should. We should get a mass adjustment request.
Yeah, and they handle those differently sometimes. Sometimes we'll get a mass adjustment request. Sometimes we will pull a list of all the effective claims. Sometimes providers are instructed to notify us. It just depends on what that guidance says once it comes out. So other question that we have here. Does WPS have any specific guidance for coverage of, and this is in quotes, surveillance colonoscopies?
I've never heard of a surveillance colonoscopy. We can check. I'm not going to to spell it right. Elaine, can you help me out? SER. SUR.
URVELLANCE.
I'm sorry, you cut out.
Oh, EILLANCE. It's not something I'm familiar with either. I'm wondering if other insurance companies have that as a term that they use.
Yeah, that's not a term that I'm familiar with either.
So I
don't know if you can. Oh, go ahead, Elaine.
Oh, I'm sorry. I was just going to respond to Leah. I guess your answer is no, then we don't have specific guidance for that term.
Right.
And I believe I'm scrolling back up here, make sure I didn't miss any. The only other question, and it's just a kind of a partial, it says, these are going to the quick, and that is in regards to the Z860100 diagnosis code. She says these are going to the quick ? So I'm not sure exactly why that is or what that is. So I'm going to wait for more information on that.
If we get notification from CMS to do mass adjustments, then that's all internal, like done here. We just adjust the claims. So that wouldn't have to go through any other levels, if that's what the question's for.
Okay, I just got another chat that says many providers refer to high risk as surveillance. Example, surveillance of personal history.
Again, honestly, your best bet would probably be to go to the National Coverage of Determination. And this is going to give you what the national guidelines are for coverage. Maybe something in here might refer to a surveillance.
Okay.
But that's the only other thing that I can think of where you might be able to find information on that.
Yes, thank you. One last chat here. All of the claims are denying the new diagnosis codes that changed.
So that must be a follow-up for the quick.
Yeah, since the system's not updated yet, yes, that's exactly what would happen.
Yeah, so yeah, we would do that. We're going to adjust those claims unless CMS comes back and says the provider needs to make us aware of any claims that denied an error. Just from experience, normally if it's, you know, something like this where you have 7 months worth of claims or 6 months worth of claims that are rejecting, normally CMS would have the MACs take care of that themselves. But again, until the direction comes out, I don't know exactly how it will be handled.
Right. Thank you for that. And there are no more questions.
Okay. That was a lot of great questions. Thank you, guys. Well, after the close of today's webinar, you should receive a thank you for attending email. Here's where you are going to find your proof of attendance and contact hours for continuing education units. This email is also going to contain a link which would give you another opportunity to provide feedback on today's webinar. If you don't get this email, then please check your spam or junk folder. You'll also need to add messenger@webex.com to your safe sender list, and that will avoid you from having any issues in the future. Now, if you joined only by phone, you will not receive this email. So if that is the case, then please send an email to the education mailbox with your name and the phone number that you used to join, and then that way we can verify that we have the information and we can send you a certificate that you can use to get your continuing education units. Now, if you do think of any follow-up questions after the webinar, you do have 7 days to send those in. You can email those to the education mailbox shown here on the screen. Be sure to put today's topic in the subject line so that staff know that your question is related to this webinar and they will send it directly to me. Now remember, if it is something that is very claim specific, those should go to customer service. I also ask that if you do send a question in to the education mailbox, please do not include any like PHI or PII. Now, when you disconnect from the webinar, you will be redirected to a CMS survey. I am also having Aline add a link in the chat, and your feedback really does mean a lot to us. We review what you have to say, and we do our best to make the changes that you ask for. This is also an opportunity for you to let us know what topics you would like to see us provide education on in the future. So if you have something specific, please add that. We would love to hear what you have. Also, if you have ideas that you think would improve how you receive your education, be sure to tell us that too. We'd like to know what your ideas are. The redirect is going to look like what you see here in the bottom middle. We don't have control over how this appears, so we just want to let you know that it isn't spam, it's nothing malicious. That brings us to the end of today's presentation. On behalf of myself, Aline, and the Provider Outreach and Education team, I'd like to thank you for being here today, and I hope that you will join us for future events. Have a great day. You may now disconnect.